Greetings, everyone. My name is Maria Bencomo, and I'm going to be presenting the case report titled Hemophagocytic Lymphohistiocytosis as a challenging diagnosis. HLH is a severe hyperinflammatory immune response characterized by uncontrolled activation of cytotoxic T lymphocytes and NK cell as histiocytes that can be familial, congenital, or acquired, meaning that there needs to be a trigger, either a malignancy or infection, that keeps this hyperinflammatory state in the body. This case report highlights the complex clinical presentation that ultimately met the criteria for HLH in a 56-year-old male, emphasizing the critical role of early clinical suspicion in managing this life-threatening syndrome. The criteria that was used for diagnosis was the 2004 criteria, which is on the right side of the poster. Now, the patient that we had was a 56-year-old male that presented to the emergency department with fever, chills, headache, and mild congestion that had begun 2 days prior, very non-specific symptoms. He had reported experiencing similar episodes 3 times over the past 3 months, with each fever lasting 3 to 5 days. These episodes were also accompanied by nasal congestion, for which he was self-treating with augmentin. He has a past medical history of Guillain-Barré syndrome, treated 3 years ago, hypertension, obstructive sleep apnea, and recurrent sinus infections. On the time of admission, he had an elevated temperature of 103 degrees, but the cardiovascular, respiratory, and neurological examination was all within normal limits, and there was no rash or icterus or cyanosis noted on the patient. Since the patient had so non-specific symptoms, a variety of tests was sent out, like CBCs, lipid panels, blood cultures, serologies, bone marrow biopsies, kidney biopsies. When all that came back, we noted that there was some transaminitis, pancytopenia, hyperferritinemia, haptoglobin elevatus, and hypertriglyceridemia. The blood cultures came back negative. The serologies came back mostly negative except for pyrovirus. In the bone marrow biopsies, we noted that there was some histiocytes with mild erythrophagocytosis, scattered foaming histiocytes, and hemoserine-laden histiocytes. In the kidney biopsy, there was acute tubular injury, very nonspecific, and we also did some abdominal CT and ultrasound that show hepatic steatosis. In the following days of admission, the patient had been developing an intermittent fever that was accompanied by an evanescent rash that would subside as soon as the fever would go down. We can see it in the image in figure 1A. Now, at this point, we were going through different differentials of what could the patient's etiology might be. We did the Q-SOFA score, which is a score that highlights if it's a septic etiology, and it was just 1, which made us rule out the septic etiology. We also used the plasmic score to see if its etiology was some type of hemolysis and inflammation going in the body, like TTP. And the plasmic score came back low, so we ruled out TTP. But when we did the Sears criteria, that was met, meaning that the patient was developing the systemic inflammatory response syndrome. And at that point, we were thinking about autoinflammatory or autoimmune processes. So we had in mind Still's disease and HLH. So we use the H score, which is a score that is used to assess the likelihood that the patient is having a hemophagocytic reactive syndrome. And our score was 259, which is a very high number, meaning that the patient most likely had a hemophagocytic syndrome. At that point, we were almost convinced that the patient had HLH, and also with the findings that we saw on the bone marrow biopsy that showed some mild erythrophagocytosis. We started the HLH-94 protocol on the 9th day, more or less. And after that, the patient had a very mild improvement, but unfortunately at that point, the patient had already been starting going through multi-organ failure. As we can see in the lab values, at some point his AST and ALTs were over 10,000. His ferritin was over 10,000 as well. And unfortunately, on the 15th day of admission, the patient passed away after having gone through hemodynamic instability and been on and off of pressors, trying to control his blood pressure. Now, this case underscores the diagnostic challenges associated with HLH, particularly in the setting of a complex clinical presentation with overlapping and non-specific symptoms, which is very hard for clinicians to assess and recognize. Our objective with this case report is to raise awareness of the clinical presentations and laboratory findings indicative of the condition, enabling clinicians to make timely diagnosis and initiate treatment earlier, ultimately improving patient outcomes. Thank you so much.